This program demonstrates the Pittsburgh Sleep Quality Index, a tool which quantifies the sufficiency of sleep and identifies areas which may affect the quality or ability to sleep. This test can be self-administered or given through an interview process. Once completed, the results can be used by nurses and the healthcare team to determine options and create a plan to improve the sufficiency and quality of sleep.
Sleep is exceedingly important to our bodies. Sleep gives us the ability to restore our health. It allows the body to rest. The blood pressure actually goes down while we are sleeping. The muscles totally relax. It allows the hormones to be excreted so that when we wake up in the morning, our cortisol level is at the highest and helps us get us through the entire day. We also know that human growth hormone is continually discharged through the night. When we have a shortened sleep, we lose that. We lose the beneficial effect of the hormones. We lose the beneficial effect of having a total rest. The heart is impacted by higher blood pressures. The muscles never fully rest.
Areas measured in the Pittsburgh Sleep Quality Index include when a person goes to bed, how long it takes to fall asleep, when a person wakes in the morning, how many hours of sleep a night does one get, what are the barriers to falling asleep or staying asleep, and what medications are being used to help one sleep.
Hi, Mr. Churchill. My name's Carol Smith. I'm a nurse practitioner here, and I have your nurse, Angela Robinson, here with us. Angela's been telling me that you've had some sleep problems.
Yes, I do, and I've been with me all my life, and I just don't naturally fall asleep, even though I try to, do all the things that you're supposed to do to, not think of things, and sometimes you get worked up, and there's a reason for it. Other times I don't see why I have such difficulty,
I'm wondering if I can ask you some questions, or if you would prefer to do a questionnaire for me by yourself, and then we'll talk about the answers. So I'm going to share the questionnaire with you. I want you to take a look at it.
So you could ask me the questions, and
Okay.
I'll try to respond, and maybe it'll be a better way of doing it.
Okay. Well, let's see. We'll start.
Okay.
If at any point in time you're feeling like it's too much,
Right.
you're going to let me know, and we'll stop,
Right.
okay?
Right.
Okay. So when do you usually go to bed? What time
I usually
at
go to
night?
bed around 11:30 to 12 sometimes.
Okay. And
Occasionally later, sometimes a little earlier.
okay. On the average, how long does it take for you to fall asleep?
It's hard to say, but I would say it seems like it's much more than several hours.
Okay. So would you say...
I might be catnapping, not realizing it, but I'm not into a real sleep.
Okay. Do you think it takes approximately 3 hours then? Is that what you're telling me?
Yes, could be often.
Okay. Right. And when do you usually get up in the morning?
Well, usually I wake around 5:30 or 6 o'clock, maybe usually before 6.
So how many hours of sleep do you feel you actually get in a night? On the average in the last month. What's it been like?
I would be very happy if I got 4 or 5 solid hours of sleep. I think I get less than that. So I would say maybe it comes out to 3 hours of sleep.
Okay. All right.
It's very hard to tell.
Okay. I know it's hard because you're sleeping and you're not looking at the clock, hopefully. So now the next part of the questions that I'm going to ask you.
At this point, Carol continues with the assessment, asking questions A through J from component 5 on the survey. We now pick up the assessment at question 6.
During the past month, how often have you taken medicine to help you sleep? Have you taken it?
I've been taking the Ambien every night.
Every night?
Yes.
Okay. During the past month, have you noticed that you've had trouble staying awake during the day?
No, not that often.
Less than a week? Less than once a
I would
week?
say less than a week. I'm thinking of...
Okay. And in the last month, how much of a problem has it been for you to keep your enthusiasm up for life?
For my enthusiasm for what, any particular thing or what?
Every life in general.
You're asking me whether I'm optimistic or not.
If I change that just a little bit to switch optimism out and to put your energy, have you been noticing a change in your energy? How hard is it to keep up your energy during the day?
I have a limited amount of energy compared to how I was. Even when my wife started a year ago in January, when my wife started getting sick. And I know I've never recovered to that point.
I think what you've also been telling me is that you've been depressed and upset over your wife's death.
Right.
And do you think this has something to do with your sleep pattern right now? Does that make it harder for you to sleep?
I guess that could be because my son was able to help me get the psychiatrist, Dr. Kennedy, and I think I started seeing him just a few weeks afterwards, and it was a good thing because I was at the height of my having a lack of appetite and where I lost the weight and very sleepless at that time.
I would like to ask just a few more questions of you.
Okay.
It's not on our questionnaire here, but it'll be helpful for me to know a little bit more about you.
Right.
Okay. Are you still seeing the psychiatrist?
Yes.
Good, good. And in addition to having some depression, are there other medical problems that you have?
Oh yes, I have. I'm treated for blood pressure, high blood pressure. I'm a borderline diabetic, which started maybe 25 years ago, and I have some arterial problems. Yeah, that's about it.
I noticed the Band-Aid on your head. Could you tell me what happened?
Yeah, I didn't lose my balance or anything, but I can't remember even how. I just bent down, and I just happened to hit the side of the furniture.
Okay.
And I have a pretty good balance usually, and I have no problem. I don't need a walking stick or a walker or anything like that. And I don't know whether it was the effect of the Ambien or what, but I do know that when I take the Ambien, at times it's like I didn't take it for a while, and that there are times when I I'm very erratic in my walking.
Okay.
So evidently there's a period of time there, a window of where I have to be very careful about my balance. When I first started taking the Ambien, I used to feel something, in a period of time, and then it stopped. And the Ambien evidently by itself doesn't work on me, where I started getting more, going under its spell. It doesn't seem to work that way with me.
Okay. It's been very helpful for you to tell me what you've already tried. Later, when we do a team meeting talking about your situation with sleep, I'll be able to share that with the team, and we'll be able to come up with some other ideas of ways to help you sleep better.
Carol, what was Mr. Churchill's score?
Mr. Churchill's score was 19, and basically he scored at the high end of the scale on most of the questions that he was asked. He also had some questions where he had a great deal of trouble pinning himself down to, well, how frequent is it? And with some people, it's going to be very hard to have a definite answer. In this particular gentleman, it's very clear that he's scoring higher than 5, and it may not be as necessary to have an exact score for that particular question. In other people who aren't scoring quite as high as this gentleman, you might want to kind of go back to that question and ask it again and see if the person can respond in a much more definitive way. And sometimes you're going to have people who just say, I just can't, I just can't answer that. And that particular question should be scored a 0. This is a good evidence-based tool to use to tell us more about a person's sleep problem. And one of the wonderful ways of doing it here in this hospital is that you have some preliminary questions on the nursing assessment that lead you to identify, well, there probably is a problem here. And you can go a little bit further, a little bit deeper. I think it's really important that you take the responsibility of not only gathering the information and scoring it, but then going forward and going to the people who are in the team for this particular patient that you've interviewed and saying, this is what I found. Can we talk about this? Can we talk about what some of the problems may be? Are there other things we need to do? Are there other referrals that need to be made? The tool has given us some very good information about Mr. Churchill. We know he's definitely has sleep problems. It's been confirmed by this particular tool. It's highlighted a couple different issues that he has. It's highlighted the issue where he's had some problems really staying asleep and also getting to sleep. It's highlighted that there have been times because of his congestive heart failure he hasn't been able to breathe, and that's interfered with his sleep. He certainly does take sleep medicine, but I think overall, he's finding the sleep medicine is not as effective now as it once was. Are there other issues that you think we should bring to the table when we meet with the team?
Well, yes, he did mention that he was a bit sluggish. He has a poor appetite.
Yes.
He has been losing weight.
He has been having a lot more difficulty keeping weight on and feeling as though he doesn't have a good appetite. And we know nutritionally that also affects sleep too.
So Mr. Churchill is a client I've been taking care of in the outpatient clinic for some time now. He's an 87-year-old man. He's a widower. He lost his wife recently, less than a year ago. And he has been expressing, concerns of insomnia. He has medical conditions including early dementia, diabetes, hypertension, depression, hyperlipidemia, and he's on several medications. So I was very concerned, so I asked Carol to do a consult on him.
Angela has told you a great deal about Mr. Churchill. Let me just add that when we did the Pittsburgh Sleep Quality Index on him, his score was way above the cutoff score of 5. He scored 19, and he has been having difficulty with his sleep for almost all of his life. He has a very hard time both falling asleep and having a very deep sleep. His sleep pattern seems to take him approximately 3 hours before he actually feels like he's asleep. And frequently he'll only have 3 to 4 hours of a good sleep. He also has had some problems recently with his congestive heart failure and needing to take extra additional diuretic, his Lasix, and this may be interfering with his sleep pattern at night too because he has to go to the bathroom more frequently.
According to the profile here, he's taking mirtazapine QD, which at least in the hospital is in the morning, and this is a sedating medication that might add to his grogginess if that's the reason for it. So what I like to do, particularly with someone with insomnia, we might want to give mirtazapine at bedtime, and that may help with his his problems sleeping.
A couple of thoughts I wanted to add on that is that my preference for the beta blocker would be atenolol, because metoprolol does have central side effects, and typically the side effect tends to be worsening of depression or depression in the elderly.
Those are excellent suggestions, and from a nursing perspective, because with all medications there are side effects. What other suggestions do you have, that are not medication that we can do before progressing to medication? Do you have any ideas, Carol?
That's a really good question, and it's one that people always want to know about. In the community setting, we take a look at the environment, we take a look at what's happening both in the furniture, in the noise factors, in the surroundings, and what the person does with their patterning before they get into bed. The environment that Mr. Churchill talked about was a really good environment. His bedroom is only used for sleeping. He has a good quality mattress. He also talked about having a set time in which he goes to bed. 11:30 he goes, and he had already tried some other tactics, we'll say, of helping him sleep, such as drinking milk and trying to listen to music, and those were not as successful on a long-term basis for him. In the hospital setting, there are a whole set of techniques that we found that have been very helpful. The research that's been done in hospitals has actually demonstrated that the more quiet the hospital setting is, the better people sleep and the better the healing is. There's a hospital project that's both here at Montefiore and elsewhere called Silent Hospitals Help Healing, and that's been particularly good. Patients appreciate that. You can close the doors a little bit at nighttime, warn people who are around the nursing station that they need to have a quieter voice, turn off the loudspeakers so that's not going off at nighttime. Also, using dimmer lights at nighttime is very effective. Trying to change the routine of how we do things with patients is also very important. Having vital signs and other testing and dressings done at a time before a person would normally go to bed. In addition to those things, we know that research has pointed out actually having a massage. A little different. We don't necessarily have a lot of massages, but even just stroking in a long stroke in the arms can be very effective and not time consuming. Sometimes playing a very soft music is really good. Sometimes adding a different pillow to the patient may be helpful as well. Those are some of the things that we can do in the hospital setting.
The TV patterns that we watch, typically late night news tends to be bad news. Well, all news is bad news on TV anyway, but when patients are watching that stuff, they tend to have a lot of emotional reactions to what's being said, because they tend to react more than a younger person who's just watching the news for news sake. So we found that that's also been a problem in many patients, and it's useful to explore that and to cut out news, or if they must watch TV, to watch some movie or something that they like, something pleasant to ease into the sleep.
Does anyone have any other comments they'd like to make?
I have one more. This could be due to a circadian problem, and melatonin is a reasonable choice, either melatonin itself that you can obtain over the counter, or drugs such as Rosarum that interact or work at the melatonin receptor site. Elders tend to have lower melatonin concentrations in their brain to begin with, and then you add the circadian issue with Mr. Churchill. That might be a reasonable choice, in particular because Ambien, he's been on it for a year and he still has issues with insomnia.
Another herbal product that I've had a lot of good results with in some patients is valerian. There are formulations available with just plain valerian or valerian with a few other combinations, but the key ingredient there is valerian, which I think is worth exploring as an option in the appropriate patient, and at least on a trial basis to see if it is effective.
I think all of you have made some very good recommendations. I'd like to go over them and put them into a summary format for Dr. Anif, Dr. Udirna, and Dr. Kennedy to look at with Mr. Churchill. I think one of the main things that we've talked about is taking a look at his medicines, both seeing if there's something different that we could do with the sleep medicine and something that we can do with other medicines that might be impairing or altering his sleep. In looking at his congestive heart failure, another recommendation that we talked about would be to reduce the time period or the times that he's actually getting that furosemide, and we're going to have to talk with him a little bit more about that too. It's really important that we continue to take a look at his sleep hygiene measures. We don't know what's going on at nighttime in his apartment, in the sense that we don't know if he listens to the evening news at 11 o'clock, and that makes a very difficult time for him to sleep. If he also tries to have multiple phone calls or other types of stimulation in the evening time. We need to emphasize and really take a look at his self-reported weight loss and lack of appetite. So I'm going to ask you if you can please take a look at other etiologies and assess him for other medical problems that might be contributing to that. Other sleep disorders that are related to medical conditions and sleep disorders that are related to substance abuse. If we look at sleep disorders related to mental conditions, we're taking a look at, primarily in the elderly, the impact that depression has on sleep, that delirium has on sleep, and that dementia has on sleep. And conversely, sleep has an element in each one of these three diseases that is greatly affecting those particular diseases as well. If we look at delirium, which is also a very prominent condition on its own in older people, many times one of the first signals that we have that the person's delirious is changes in the sleep pattern. People are awake at nighttime. Differently than other types of sleep disorders we're going to talk about, delirium presents with an intermittent wakefulness that is not there prior to an event that's causing the delirium. It's important that we don't miss this particular signal. It does require talking to other family members about it in order to know if this is new, was this different, and then seeking an answer as to what's causing it. If we go on to people who have dementia, then we're also looking at a reverse sleep-wake disorder that is part of the dementia and part of the changes of the brain architecture. In order to get more information on this, we need to know about the past history of the person. We need to know what the environment is like in the home or in the institution that the person is in. And sometimes we can affect changes, but it requires a team effort to really piece together the history with that. When we're talking about depression, we know that for many people, one of the first signals that there is a depression in older adults is a change in sleep or eating habits. Many times older people don't really say that they're depressed, but there's a change in their functionality, there's a change in how well they're sleeping, and in our assessment we're taking a look at sleep as one component of the depression. If we go on to medical disorders, then we're talking about obstructive sleep apnea, where the person is not having a good type of breathing at nighttime. They're waking up because they're not getting a good deep sleep. They may or may not benefit from having a BiPAP machine to help them sleep better. Sometimes this is also impacted by weight, and helping to adjust the environment can be helpful to those people too. Many times this requires a pulmonologist as well as perhaps a sleep clinic to help diagnose this particular obstructive sleep apnea. When we also look at medical disorders, we can look at the impact that restless leg syndrome has on sleep. Again, it's activity that perhaps the person, him or herself, is not aware of, but their bed companion may be aware of, the family may be aware of this, and this too has a medical associated relationship with sleep. There are times in which that person may need to be referred to a neurologist to really help get a handle on what's causing that. A couple other medical conditions. One is congestive heart failure, and which the person has difficulty breathing at nighttime when they're in more of a supine position than a sitting position. It can also take place when we are giving people who have congestive heart failure diuretics to help reduce the fluid that they have, and we automatically make them go to the bathroom many times during the night. Another common medical condition that does affect sleep is diabetes. In research that's been done, there seems to be a direct relationship between the quality of sleep and the glycemic control that the person has. In addition to the sleep disorders I've already talked about, one last one I'd like to mention is substance abuse. And while many times older adults may not have access to street drugs and don't use street drugs, alcohol, and over-the-counter sleep aids can sometimes influence and cause a substance abuse sleep disorder. It is something that we really need to take a look at, how and when people use alcohol and over-the-counter sleep medicines. Sleep disorders are very prevalent in the geriatric population. We know that people who are aged 80 years to 89 years old have one of the higher percentages of a sleep disorder. In a telephone survey that was done in 2003, it was indicated that approximately 2/3 of all older adults have some form or some symptoms of a sleep disorder. It's thought that nurses and healthcare professionals do not really assess fully for sleep disorders in older adults. It may be because we're in a very difficult time in our healthcare situation where we don't have enough time to ask all the questions, and it may also be that people don't have enough time to really tell all of their health problems when they come to see a provider. We're in the process of trying to make the American public, as well as the healthcare professional, understand that sleep is a vital part of our life force and needs to have a very good assessment done for older people. There are several sleep tools that are available to be used. The one that has good reliability and validity has been used throughout many parts of the world and also with different populations has been the Pittsburgh Sleep Quality Index. It's not the only tool out there, but it's a very well-used tool. It can be self-administered. It can also be administered by someone else to a patient. It takes relatively little time, anywhere between 5 and 20 minutes, depending on how a person wants to delve into the questions and how much they have to say. It is a key to learning a lot more about the sleep habits of a person and being able to then take it forward to do more of a sleep assessment if that's necessary. When people score over 5 on the tool, there is an indication that they may need other assistance, other evaluations done. And those other assessments may need to be done by specialists such as neurologists or psychiatrists or a geriatrician. It may also require the help of a pharmacist to determine what other issues are causing the problem and how they can be helped. It's wonderful if you have somebody who can take this tool and do it independently, and then you just come back, you look at it, you score it, and you talk with them about what it means. But frequently you're going to encounter people that need a little extra help. And while the tool can be administered within a short time period, there may be people who need to talk, who need to give you a lot more information in response to the questions. And for those people, it could be 20 minutes of your time. Having a unified support from administration and from the staff on the floor to be able to conduct these types of questionnaires is beneficial. It helps to support you. And if there are other initiatives in the hospital looking at ways to improve quality of care for patients, then this is something that can be posited as an additional quality improvement questionnaire.